everyone, and welcome to our POSSE webinar on health literacy basics. Thanks for joining us this afternoon. A little intro. So my name is Susan Cosgrove. I'm from the Healthcare Improvement Foundation, and HCIF is a nonprofit organization in Philadelphia, and our mission is to drive high-value healthcare through stakeholder collaboration and targeted quality improvement initiatives. And our goal is really a responsive, coordinated healthcare community that fulfills the needs of patients and consumers and achieves better health. The Pennsylvania Opioid Surgical Stewardship Enterprise, or POSSE, is a program in HCIF, and this is a 2-year collaborative. It's funded by the AmerisourceBergen Foundation, and it's a partnership between HCIF and the Pennsylvania NSQIP Consortium, or PANC. And our goal here is to focus on patient and provider-centered domains to prevent post-operative opioid abuse. And this webinar is one in a series of webinars that is intended for our patient and family advisors that play a key role in developing some of the educational materials that we'll be using for the POSSE program. So as I said, I'm Susan Cosgrove. I'm the Director of Health Literacy at HCIF. And then our other presenter today, who you will hear from in a little bit, is Kelsey Salazar, who's the Project Manager for POSSE and the Population Health team here at HCIF. So we're happy to be here with you presenting on health literacy today. Our learning objectives are to define health literacy and understand its impact, to implement some basic strategies to improve communication between patients and providers, and then also to understand the importance of patient and family advisory councils in promoting health literacy and in improving care more generally. And so we're going to start today with a couple of videos. So we'll start with this Health in the City video. So this video is actually a public health student project from a few years ago that we like to use to start our health literacy trainings.
Hi, I'm Cassie.
And I'm Blair.
And today we're on the streets of New York interviewing people about their health literacy. Can you describe to me what hypertension is?
I'm guessing it's when you're really hypertense. I have no idea.
No, but it sounds bad.
I don't know that.
Hypertension would be overactiveness in the muscles.
So is it when you stress a muscle or something like that?
No, actually in the mind maybe, hypertension.
Hypertension is like a mental disorder.
I don't have it though.
To be treated with the proper medicine.
Hypertension would be overactive stressfulness.
I don't know what medicine it is. Maybe Haldol, Prozac, Prolixin, something like that.
Do you know what angina is?
Angina? I don't know, but it sounds pretty cool. No, I don't know. I don't have a clue what angina is.
What is it?
No.
Sounds like something familiar, but I don't know.
Do you know what a stethoscope does?
Is it the same thing as a microscope or is it a totally different thing?
Nope.
No.
What's the first word that comes to mind when you think of your relationship with your doctor?
I lied.
Difficult. Brief. Sometimes they don't listen to what you're saying, or that they go so quick that you don't understand what they're saying.
The doctors don't spend enough time with the patients that come in.
He never spends enough time listening to what I have to say.
Doctors do not communicate with me enough. Because I ask him every time, what's the matter with me? He said, Jason, you're crazy. I went to my doctor and said, no one takes me serious. And he said, next.
They listen to your input in the beginning to figure out what the problem is, but after that, I don't think they care about what you think.
I'd like to see it more honest, open communication.
I don't think they always explain it to the patient in the same way that the patient would understand. Pro-doctor, but everybody is not at the same level, and sometimes I think they need to explain it a little simpler.
They went to college, they went through so much school, and they do not communicate, obviously not.
That's what we found today on the streets of New York. Do you think there's a problem?
Great. Great. So as I said, that was a video that was created by two public health students, and it features obviously real people, which is one of the reasons why we like to use it. And moving forward, the next video that we're going to show, this is actually a video that was produced by the American Medical Association, and this video also features real patients as well.
I was sick a lot. I was sick a lot because I probably missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them, and I didn't want anyone to know I couldn't read.
I can't read this. Well, I guess doctor gave it to me, so it's okay for me to take it.
When your children have fever, what do you usually give them?
Motrin or Tylenol. Normally Motrin because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4, okay.
I would give her the 4 to 5, a tablespoon and a half.
One capsule.
That's right, one capsule?
One capsule. I don't know what this is. Twice daily.
Okay. So how would you take this?
When I see it's not on there, tell you how to take it. It say take it twice daily, but it don't say what time to take it.
Do you know what hypertension means, if I asked you what that was? Because when I look at this, I think, well, maybe you have hypertension, and I've been taking care of that for a long time.
Hypered? Hypered.
Like you're hyper? What does being hyper mean to you?
That's where you can't be still. You always got to be doing something.
Do you think I think you're hyper and have hypertension?
Yeah, I don't know. That's what I consider it.
Okay.
Being,
Okay. But you know you have high blood pressure. Okay, but hypertension doesn't mean the same to you.
I have a small breakfast, and then I take my pills. I usually take 16 every morning. Sometimes it's difficult for me to take these pills because if they say 1 tablet twice daily, I don't know if they're talking take 1 in the morning, 1 in the evening, or take 1 in the afternoon or 1 in the evening. So usually what I do is take 2 of them in the morning. Then this way I know I have them.
If you have a reading problem, you go to the doctor. That can be very scary. It's like a nightmare. You walk in that office, and most people, if you realize the first thing you're going to have to do if that's your first visit is fill out a form. Your heart beats real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign. Never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it.
So generally at our trainings, we like to start by showing these 2 videos together. The first one is obviously a little bit lighter, and the second one really ends on that very serious note, I think just demonstrating, the extent to which health literacy can result in patient harm and can really be a source of shame for patients as well. So for the first video, we try to have a discussion with folks, and some of the reflections that we often get are, these folks look very familiar. They could be my friends, my family members, or my coworkers. They come from all different backgrounds. You can't tell what a person knows based on their age, their gender, or their ethnicity. When we have physicians in the room in particular, or other clinicians, we often hear, I thought that everyone knew what hypertension was, or I assumed that everybody knew what a stethoscope was. And there's a real aha moment, when these words are sort of identified as being jargon that not everybody would know or recognize immediately. And for the second video, we often get similar observations. What we like about this video is that it shows kind of everybody's education level and reading level and occupation, and demonstrates that you really can't make assumptions about general literacy or health literacy based on those things. So based on education, occupation, looks, or even how someone sounds. Patients feel very ashamed. They often feel like it's their own fault if they don't understand, and they will work very hard to hide that. And oftentimes we have clinicians who reflect and think back to times when they thought they were communicating clearly and realize maybe I wasn't, or maybe that patient that was not taking their medication correctly, maybe they just didn't understand how to take it. And so these are some of the discussion points that really come up when we generally show these videos. And with that, I'm going to hand it off to Kelsey to talk a little bit about health literacy.
Hi, everyone. It's so nice to be here talking with you today. The videos really showed us some of the ways that health literacy and not understanding your interactions with the healthcare system can affect a patient. And this next section, we really just want to go into what health literacy is, what it really means, and why it matters. So some of the things that we want to start off with are just an understanding of the healthcare process is really complex. Like if you think about what we ask a patient to do, even for a single appointment, there are a lot of steps that they have to take. They have to call to get the appointment in a time that fits for them and for their healthcare provider. They have to navigate their insurance. They have to understand what their coverage is. They have to get to the appointment, even if they have transportation issues and maybe if they're working. They have to sign in with registration and fill out a number of forms before they even get to the appointment. And those forms might be about their medical history, but they might also be expected to know the medical history of all of their immediate family members. And then once they're in the appointment, they have to communicate all of the information about the symptoms they're having, how they've been feeling, and get information back from the provider in a way that they understand about their diagnosis and what it means and what their treatment is and what the follow-up steps are like. And then those follow-up steps, they have to get their medication. They might leave with a stack of papers that are educational materials or discharge notes. And then they might have other changes that they have to make in their life, like lifestyle changes or behavioral changes that are affected by that encounter with their healthcare provider. And this is all just for one visit, to get a vaccine, or if you're sick and you have a cold and you want to go to a doctor. But we ask patients to do this all the time, and sometimes for incredibly complex conditions that require them to go into the healthcare provider all the time. And if you think about how communication challenges can really affect all of these steps that a patient has to do, it can make it even harder for a patient to navigate, because communication is a two-way street. So if a patient seeks medical help and the forms that they get when they go to check in are really complicated, and a doctor or a nurse doesn't explain the condition in really clear terms, but they use a lot of medical jargon and terminology, and they leave with a stack of papers, and the provider doesn't check to make sure that the patient has really understood what they've discussed that day, and no one follows up with the patient to check in with them and make sure that they're clear on what they're required to do after they leave the healthcare system, then that can really lead to a snowball effect of, negative outcomes and things that we don't want to see our patients suffer through, like not taking their medication appropriately, or not making follow-up appointments, not making the proper lifestyle changes, such that, a patient's condition might get worse, they might get sicker, they might end up in the emergency department, and then the whole cycle continues. So this really leads us to a good question, which is, we've seen some of the effects of, people who don't necessarily have great reading skills, but what is health literacy? And there are a number of different definitions that people have come up with throughout the years, but one of the ones that we like to use is from the National Academies of Sciences, Engineering, and Medicine, and they define it as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate decisions regarding their health. So a couple of things I want to pull out about this definition. The first is that it's based on individuals, right? It's what patients are able to do. It's how patients are able to interact with their health information. But as we said before, communication is a two-way street. And so patients and providers really have kind of a mutual responsibility to make sure that they're both communicating and understanding one another. One of the other things is that, this definition of health literacy is really focused around basic information and services. So kind of what a patient really needs to be able to understand their health and to be able to synthesize all the information they're getting and then act on it from there. And the other thing that I want to point out is that when we talk about the capacity to obtain, process, and understand information, that really refers to a number of skills. Patients are required to read and to be able to interpret things like graphs and charts and have good numeracy skills, to listen and understand, and then to be able to synthesize all of this and then act on it. So health literacy is actually a really complex set of skills and processes that we expect patients to know and be able to do. So there are a number of different things that impact a person's health literacy level, and some of those things are things that we're born with, like our language and our culture, our race and our ethnicity, and some of those things are things that really influence and kind of our social structures that influence the way our lives go, like our education and our occupation and our income level, our social support and who's in our lives. And then some of those things are things that, change over time, like as we age, our vision level, our hearing abilities, our reasoning, and our memory. And these are all individual level factors, and it's important to remember too that some of these things can change, and that a person's health literacy level doesn't necessarily stay the same from day to day. If you get a very scary diagnosis, that's going to affect how much information you can process in the moment. If you usually read pretty well, but you're getting older, you might not be able to see the words on the paper as well. Or if you happen to be in a different country where they speak a different language and you have a medical emergency, things are going to be much harder for you to interact with your healthcare and understand everything that they're telling you in that type of situation. So everybody's health literacy can differ at different points in their lives and from day to day. And those are some of the personal and individual factors that impact a person's health literacy level, but there are a lot of things at the system and situational level that can affect health literacy as well, including how complex and complicated the information that a patient is receiving is, and also the ways in which it's communicated, through hospital signage, through directions on a website for how to get to a clinical place, through any other types of navigation, and through the amount of time that a person has to process these kinds of things. So that kind of was a general overview of what health literacy is and what can affect it. But there are a lot of reasons that health literacy really matters too. And I think that we saw a lot of that when we watched the video. We could see the shame that it brings upon people when they have low health literacy skills. But there are other things too. Health literacy research shows is a stronger predictor of an individual's health status than any of those other demographic factors like age, income, employment status, education level, or racial and ethnic groups. And according to that National Academies of Sciences, Engineering, and Medicine, efforts to improve quality in healthcare or reduce disparities in healthcare across different patient groups or to reduce costs they can't succeed without improving and addressing health literacy needs. Health literacy also matters because different research studies have shown that if a patient doesn't have the needed skills to interact with the healthcare system and understand it, then it can lead to 4 times the healthcare costs, 6% more trips to the hospital, and up to 2 more days in the hospital, which are all things that affect both the patient and the providers in the healthcare system. Health literacy, low health literacy is also related to a lower health knowledge and lower healthy behaviors, not using preventive services as much, which can lead to poorer health outcomes, and needless patient suffering, as well as greater health costs, not just for the patient, but for the entire healthcare system through repeated hospitalizations or using health services too much and not really knowing where to go from the start. And these are a lot of really negative outcomes that we've talked about, but it's important to remember that in that kind of two-way street of communication between a patient and a provider, there are specific communication techniques that can help address and mitigate some of these problems that come from health literacy needs. And that's something that we'll get into in a little bit. Before we do, one of the things that we like to do when we have these trainings in person is to give people kind of a sense of what it really feels like to go through life having low health literacy. So we're going to do a little exercise here. I'm going to switch to the next slide, which has a passage on it, which simulates what a reader experiences when they have low health literacy. And I'll give you probably 30 seconds and just make sure that you're on mute if you are watching the webinar live. And while you look at that next passage, read the passage out loud, get through as much of it as you can. And just as a hint to get you started, when I turn the slide to the next one, the words are written backwards and the first word is cleaning. So 30 seconds on the clock. All right, your 30 seconds are up. Usually when we do this exercise in a room, what ends up happening is we all kind of end up reading it very slowly together. So we say cleaning, to assure high performance, periodically clean the tapes, heads, and capstan. And what happens is sometimes people read it a little quicker than some other people. You'll sometimes see like a lot of people like pausing on a certain word that's longer. And we just kind of go through it, and it's always a little bit chaotic because no one really quite understands what's happening. And I think it really goes to show when you see this block of text and you just think, what is this? If you think back to some of those patients that we saw in the video earlier, this is their reality every day of their lives. This is their reality every time they come across a patient educational material or discharge instructions. And some of the things that we hear from people after they do this is that, they got through it, but it wasn't easy. It was a continual struggle, or that they're exhausted. It took them a lot of mental effort and space to be able to read it, or that, they were frustrated and irritated and they just gave up because they didn't want to put in the effort after some time. And I think it just goes to show that, the very last comment that we get a lot is that it just gives people a whole new perspective on how patients might really be feeling. And then just something I'd like to point out, when we ask this question, how do you clean a capstan? People just kind of go, what? Like, I still don't know what a capstan is. Maybe it involves, alcohol or, but the real takeaway is that everyone is so focused on trying to get through the passage and understand word by word that they miss the main message or the meaning of the text. Which I think is something that happens very frequently when patients are looking at materials. And just for your information, the capstan is the part of a tape player that moves the tape through the device. And if you're like me, when you read that definition, and even when you look at this graph, like you still don't really know what a capstan is, and you still don't really know how to clean it, which I think just goes to show too that, you know, when providers use really technical jargon or unfamiliar language or introduce concepts in healthcare settings that a patient has never heard before, even if you think that a patient might know it, like, for example, stethoscope, like we talked about earlier, it just adds another layer of complexity and difficulty to a person being able to understand and act on their information. So you might notice some signs of patients maybe not having all of their health literacy skills. They may not fill out their office forms completely. They may tell you that they forgot their glasses and they're just going to read the papers at home. Some of the things that we usually associate with noncompliance, like not taking their medicine properly or missing appointments, might really be underlying issues related to health literacy. If they can't really explain the purpose of their medication, or they can identify what medication is which by looking at it, but not by reading the label. And if they're not asking you a lot of questions, then those might be some signals that someone is struggling with low health literacy. But it's also important to remember that patients who have low health literacy have been dealing with this all their lives, and they're very savvy and very practiced at hiding the fact that they're not comfortable with their reading level from everybody, including providers. And even though there are some signs that you might be able to see, it's also really important to remember that you can't tell by looking at a person. I think that that was really clear from the first video we watched. And also, since we know that health literacy can really vary person to person and day to day, and we know that only 10% of adults have all of the skills that they need to use health information that is available to them, then we know that almost everyone that we're interacting with in the healthcare system is likely to have some sort of problem with their health literacy level.
Thanks, Kelsey. This is Susan again. I'm going to take us home. So we've talked about what health literacy is, what some of its impacts are, and why it matters so much. And so now we want to get into some of the strategies that we use to address health literacy. So just a brief overview of the strategies. So we'll talk in more detail about each of these. But first, we recommend implementing a universal precautions approach and creating a shame-free and blame-free environment. Improving interpersonal communication through implementing a number of techniques such as teach back or show me, using plain and living room language rather than medical jargon, and really encouraging questions and engagement, and creating and using patient-friendly materials. So the universal precautions approach. I think this really gets to what Kelsey was just saying about health literacy being an issue that pretty much everybody can or will struggle with at some point in their lives. And so we want to deliver healthcare as if everybody could potentially have trouble understanding the information that we're giving them. And this is the universal precautions approach. Sometimes when we deliver trainings to clinicians, they say they're concerned about potentially dumbing down information for patients, but that's really not a valid worry. What study after study has shown is that even patients with higher literacy skills can have a hard time understanding medical terms and conditions, particularly newer ones or ones that are, upsetting or traumatic to hear about, and that every single patient, regardless of their health literacy or their general literacy level, will really appreciate receiving easy to understand health information. I think rarely, if ever, would you come across a patient that would really prefer that, they are handed a stack of journal articles to read about their condition. Folks really like to have brief information that tells them what they want and need to know and what they need to do sort of immediately as follow-up to their appointment. And a big component of the universal precautions approach is creating this shame-free and blame-free environment. And we really try to promote this with the healthcare organizations that we work with because this isn't just about patients, it's also about staff. So in a shame-free environment, questions are encouraged from patients and from staff members and colleagues. It's good to let patients and clients know that others have difficulties and encourage them to share their concerns and problems. So you're really creating a trusted relationship where patients feel safe, sharing any struggles that they're having. You're defining medical and scientific words and only using them when needed. So really trying to avoid medical jargon wherever possible, but we do recognize that sometimes it's impossible to avoid it. So making sure that those terms are being defined, and just generally protecting patients from embarrassment in front of others and showing respect. So you can see some of these are sort of specific to health literacy, but most of these are really just good practices for making patients feel comfortable and creating a patient-friendly environment. And on the blame-free side, an organization that has a blame-free culture is really fostering an expectation of collaboration across ranks. And so health literacy is the responsibility of all staff members, from the person who's at the registration desk to the physicians that are seeing patients. And there's also a willingness from the organization to direct resources to reduce and meet the health literacy needs of their patients. And so as far as improving interpersonal communication goes, I'm going to talk through a few topics here. The first one is teach back. So teach back is a way to confirm understanding. What's most important about teach back is that it is never a test of the patient. It is always a way to demonstrate that the provider has communicated effectively. And the process for teach back goes like this: if I was doing teach back, I would explain something to you. And then I would ask you to, in your own words, with a non-judgmental question, explain back to me what I had just stated. So I could say something like, how are you going to take care of yourself, or what are you going to do when you get home from this appointment? That would give you the opportunity to tell me what your plan was, and then if there were any misunderstandings or any information that I felt like I wanted you to have, we could have a dialogue, and I would be able to clarify that, and you could ask questions, and so we could come to a place of mutual understanding where you are leaving your appointment feeling confident that you know what you need to do to take care of yourself. And what's key about teach back is really making it something that is not judgmental. So, we recommend questions like the ones here. We've gone over a lot of information today. Can you tell me what we've discussed? How will you make this work at home? What will you tell your spouse or your family member or your friend about your condition? And this one is one of my favorites. I want to make sure that I explained it correctly. Can you tell me in your own words what we talked about today? Again, coming back to that idea that teach back is really about confirming understanding and verifying that the communication has happened effectively, not about testing the patient. In conjunction with teach back, we always recommend the use of plain language or living room language, and we recommend this whether it's conversationally or if the information is written down on a page. This makes health information much easier to understand. And the keys to using plain language are to speak as if you are talking to a friend or family member. So just like you're having a normal conversation with someone. You want to use simple language, simple sentences, again, coming back to defining technical terms when you must use them, if there's no simplified option. And you always want to use the active voice. So using the active voice would be saying something like, for example, eat a variety of fruits and vegetables, as opposed to saying, it's best for you to eat a variety of fruits and vegetables. Just really simplify those sentences, make them action-oriented, and use the active voice. Additionally, we recommend limiting information to the 3 to 4 most important points, and this is whether it's a conversation or in written materials as well. And particularly in written materials, it's important to organize information so that the most important points come first. So you don't want to put sort of the need to know on the very last page of a brochure or sort of at the very end of a document. You want it right up front and center so that somebody will take note of that and it'll be one of the first things that they see. We also recommend breaking complex information into understandable chunks and giving patients only the information that they want and need to know. So if you think about yourself as a patient, in the doctor's office, particularly, again, if you're in a situation where you're facing a diagnosis that's new or you're receiving a lot of information that you're unfamiliar with, you don't want to receive 100 pages of information. You really just want to know the basics, like what do I need to do so I can go home and I can take care of myself. And that's really what we recommend focusing on. There are lots of resources out there that can help with word substitutions. There's at least 2 plain language thesauruses out there. You can see here in the left-hand column, we have sort of the medical jargon word, and then in the right-hand column is really the word you could use instead. And I think some of these words you wouldn't necessarily think are complicated or are necessarily medical jargon. Something like intake seems like a relatively simple word. In a reading level test, it's a 2-syllable word. It would not be considered a high reading level word, but it's something that has a very specific meaning in a clinical context that someone might not be familiar with. So another great example of this is thinking about positive versus negative test results and what those words mean. So if somebody has a positive result on a test, that could actually mean something bad. That could mean that they are positive for a condition that they don't want to have. But saying the result was positive, patients have a different understanding of the word positive. So it's just things like this that I think sometimes, you know, we're on autopilot, we use these words all the time. It's really good to just take a step back and think about, again, incorporating plain language, thinking about how you would explain these things to a friend or a family member. And then finally, for both patients and providers, we just recommend encouraging questions and engagement. There are a lot of different sort of resources and campaigns out there that are related to question asking, so be more involved in your healthcare, as different tips that you can use before, during, or after an appointment. My questions for this visit, you can use this resource to list out the questions that you want to ask. And then Ask Me 3 is a program that we actually use for some of our health literacy initiatives. And Ask Me 3 really encourages patients to ask 3 questions at every healthcare encounter. So what is my main problem? What do I need to do? And why is it important for me to do this? And I think what is most beneficial about the Ask Me 3 is these 3 questions are great, and I think having the answers to these questions can really help someone understand their healthcare. But I think what's more important is just getting folks in the habit of even asking questions and being comfortable engaging with their providers. We use this program very successfully with a lot of the senior citizens that we work with in our health literacy initiatives. And oftentimes they tell us just that they weren't used to asking questions of their doctor prior to sort of implementing and using this Ask Me 3 program. And it really opened the door for them to ask these questions, but to also ask other questions on top of them as well that help them take better care of themselves. And then finally, we recommend creating and using patient-friendly materials, which is something that we are going to get into a lot with the POSSE Patient and Family Advisory Council. So at a very high level, patient-friendly education materials are easy to read and understand. They appeal and are relevant to the intended audience, and they convey a clear and simple message. And the key thing about patient-friendly materials is really your material is patient-friendly when your intended audience says that it is. And that's one of the key roles of the PFAC for POSSE, is going to be providing us with feedback on materials to ensure that those materials are patient-friendly, are easy to read and understand, and are really applicable to the intended audience. Some general steps for creating patient-friendly materials, again, coming back to defining and involving the audience, really identifying who you want to speak to with your materials, whether that's a brochure, a pamphlet, a booklet, or a video. And then you want to select an appropriate format for your audience. If you know that your audience prefers to learn by watching videos, then it's better off to make a video than to make a brochure. You want to write the material using easy to read best practices. This includes the use of plain language, short sentences, limiting information to the 3 to 5 main points like we talked about. And then you want to conduct quality assurance checks, and the best way to do this is just to do a materials review with your intended audience, which again is going to be a really important role that the POSSE PFAC plays. So if you want to learn more about creating and using patient-friendly materials, we actually have a webinar 2 weeks from today on July 31st, where we'll go into this topic in greater detail. And that webinar is Tools for Reviewing Patient Education Materials. After this, we'll send out a link so that you can register for that if you're interested in participating in that. Okay. So now that we've gone over several strategies that we recommend for addressing health literacy concerns, I want to just spend a few minutes talking about the importance of patient and family advisory councils. So the POSSE project is the first program that HCIF has had where we are working to establish a patient and family advisory council. And this is because we just felt it was really important to have the voice of the patient represented in this project. So we spend a lot of time working with clinicians, working with providers and physicians and nurses and other sort of hospital staff. And we just felt like to create the materials that we wanted to, the education materials on opioids for this project, we needed to have patient feedback on that. And patient and family advisory councils, I think, are a newer thing, but increasingly hospitals have them. And what they really do is help healthcare organizations understand what patients and families want and need when receiving care. And the depth of knowledge and feedback that PFACs can provide really just goes beyond sort of the typical information that hospitals receive if they're distributing patient satisfaction surveys after visits. So patient and family advisors can offer insights about an organization or provider's strengths and weaknesses when it comes to serving patients. So they can observe things like wait times for appointments, you know, whether a facility is easy to navigate or not, whether phone menus are easy to navigate, sort of other feedback on environmental pieces. They can provide feedback on practices, policies, and materials. So this can be sort of after these practices and policies are established or after the materials have been created. But what PFACs are really, really great at is being part of the process while these things are being written, things like policies and practices. I think to have the patient voice at the table is invaluable. And then again, just offering a fuller picture of the care experience than surveys provide. And PFACs are important because generally when PFACs are involved, they result in better systems and processes of care. And some of the long-term benefits can include better health outcomes for patients generally. We see fewer errors and reduced risks at facilities that use PFACs, increased patient engagement and loyalty, and even increased employee satisfaction, which I didn't know was a benefit of having a PFAC, but I thought was interesting to hear that staff at organizations that have PFACs generally report increased satisfaction. So we take the role of a PFAC very seriously, and we really value the patient voice, again, in this project. And PFACs support health literacy specifically in a number of ways. So this can involve providing detailed feedback on patient-provider communication. So for example, if a hospital wants to implement TeachBack and wants all of its staff to be using TeachBack, patient and family advisors can really be helpful in doing some of the coaching and providing feedback around that, and even providing feedback as to whether TeachBack is actually being used. A big role, as I mentioned, of the POSSE PFAC is going to be reviewing educational materials to ensure that they're patient-friendly, and then providing feedback to make them more health literate and more patient friendly. Identifying care processes that are confusing or unclear. Sharing patient stories about health literate care. I think this is a really important role that patient and family advisors play, is kind of sharing the good, the bad, and the ugly of their care experiences. So what worked really well, what they really appreciated, you know, what kind of made their experience harder or more challenging, and what can really be done to improve care. And again, just ensuring that the voices of patients and families are part of larger scale planning and decision making at healthcare organizations. And for POSSE specifically, what we want to do is promote health literacy and patient-provider communication related to opioid use and pain management, and increase the number of health literate patient education materials. And again, the PFAC is going to play a big role here. So what we're looking for in our POSSE PFAC members, ideal PFAC members will have one or more of the following qualities. So because this collaborative is focused on surgery, we're looking for folks that, as a patient or a family member of a patient, has had surgery in the last 5 years. Empathy and understanding for issues related to substance use disorders, which we feel like is a really key trait to have when you're talking about opioids and the opioid epidemic. We're looking for the ability to participate in trainings and meetings like this one, virtually and in person, and time to independently review patient education materials. The ability to listen, respect the perspectives of others, willingness to share your own experiences and interact with many different kinds of people and work collaboratively, and really just a passion for improving healthcare for others. And the expectations for our PFAC members will be to participate in 3 virtual training sessions. This is the second of the 3. The first one was a webinar on stigma and bias, so the recording is available. And then, as I said, the third one will be in 2 weeks, and that one will be focused on materials creation and review. And then we have one in-person session at this time. That session is tentatively scheduled for September 25th. We'll be following up after this webinar with that information. And then perhaps a second in-person session for March 2020. And then we're asking our PFAC members to review patient education materials and provide feedback on their look, feel, relevance, and clarity. And as I said, the next webinar is really going to focus in on that and give some tools for doing that. We will review patient education materials of all different formats and of any length. For all of the hospitals that are engaged in POSSE, we've asked them to submit the patient education materials that they're currently using and currently giving to patients postoperatively. And they include one-pagers, pamphlets, brochures or booklets, forms or charts. We know at least one hospital has a video. We've also received post-discharge call scripts from one hospital to review as well. So a really nice sort of diverse package of materials that our PFAC members will be looking at and providing feedback on. When we send out the slides, we have the link in here for our first webinar recording for stigma and bias and attitudes about opioid use. I will insert the link for the recording for this webinar here, so that'll be in the slides, and then the registration link for our next webinar, which, as I said, will be in 2 weeks, and then our first PFAC meeting will be scheduled for September. So in summary, what we are seeking to create at the Healthcare Improvement Foundation across all of our projects is really a health literate and patient-friendly system where a patient seeks medical help and can really get the help that they need. So they enter a patient-friendly and health literate environment. You know, they never feel stuck. They never drop out of the system at any one of the many you know, confusing points that Kelsey walked us through. And they're able to really connect and have a trusted relationship with their care providers and receive the care that they need. And that's our goal, and that's what we're working towards with this and all of our projects here at HCIF. So thank you for joining us on today's webinar. With that, I think we do have a few minutes for questions. If anyone has any questions that they would like to ask us, we're happy to answer, and if not, then we will plan to end a couple minutes early, but please feel free to jump in with questions. Okay, well, if something comes to you, here are our email addresses. If you'd like to shoot us an email and ask a question, we will follow up also with an evaluation for this webinar and the recording as well for everybody who joined. Thank you so much for joining us this afternoon, and we'll be in touch. Have a good day.